I started out my studies in chemical engineering at the University of Washington, kind of always had an interest in engineering, and then found I enjoyed the clinical aspects of certain interactions, spent some time in a hospital and in a dental practice. So went to dental school at the University of Washington, went to San Antonio, did a lot of research at that point, did a lot of growth factor research and really got interested in wound healing. And last 20 years has flown by very quickly with all the different research and exciting technologies, but been interested in implants for that whole 20-year process, and really enjoying the fact that a lot of our early work is now coming to fruition. In addition, currently I'm in private practice, but I do teach at Oregon Health Sciences University and then have a variety of positions with the AAP and try to help out in the research front. So I get a nice blend of private practice with academics and organized dentistry. Well, it's really exciting how tissue engineering is impacting the private practice now. I think we're going to see a slow shift from taking out teeth to starting to save teeth. I believe that we'll be able to be more effective at saving teeth, which actually would reduce the number of implants that we're doing. When it comes to implants, I think having molecular and cellular approaches, what it's done is it's minimized the amount of autogenous grafting that I do. It's also, I think, leveled the playing field. I've worked with the residents and I've seen some pretty amazing results very early on in their learning curve, because sometimes these products can help you with the flap management. For example, recombinant human PDGF can maybe enhance the soft tissue healing. So if a resident isn't as careful and meticulous with the flap as maybe I would be, they can get similar results oftentimes. So I think it's been exciting how it's leveled the playing field and reduced the need for autogenous grafting. I think the amount of research is phenomenal, especially when you look at BMP2. The amount of study that has gone into that molecule is amazing. The problem that we run into is that clinical FDA approval procedures oftentimes don't replicate exactly what's done in private practice. So while there are a tremendous number of studies out there with PDGF, BMP2, and there are some studies with the cellular allografts, oftentimes what a practitioner is doing is something very different. I'll just give you one example. BMP2, the studies are with a collagen sponge, and then in private practice some people are mixing it with something else. And so I think what's important is that the clinicians realize there's an excellent body of literature showing the safety and the efficacy of these products, but as we move into the clinical optimization aspect of these, that they have to understand that material may behave completely differently with a different delivery device as opposed to the collagen sponge. And that's just one example, but that goes for all of these products. As we do our own little recipe, it can impact our outcomes. Well, it has become very complicated now that we have so many choices available to us with these molecular approaches and the cellular approaches. In my particular case, what I try to do is look at the defect and determine what I think would be beneficial, and then help the patient make the decision. There'll be times where I believe all three, PDGF, BMP, as well as a cellular allograft, might be just what I want to do to kind of give that case a little bit of a boost, because it's a little more challenging. And then oftentimes I will let that patient make that final decision, because ultimately each one has a slightly different technological base to it, and I think that's important. They also have different price points to them. So when the patient looks at the differences and looks at the cost, sometimes they make the decision. If it's purely me making it, I think as I get into larger defects, I think I like the cellular component to it. Delivering the cells is great with the cellular allograft. I think if I need a case where there's a lot of angiogenesis required, there's soft tissue issues, I think maybe around periodontal defects, the PDGF is great because we know the angiogenesis and the soft tissue healing can be good. The BMP2 works beautifully in the bone grafting arena, and so I have very good success with it when utilized in the right circumstances. I think with titanium mesh for the space maintenance with the collagen sponge, you can get a really nice result with that. Well, we have a charge for autogenous bone, and so really the pricing is related to what a non-cellular graft, such as a classic allograft or cellular graft would be, and then comparing to autogenous. And for me, it still is less expensive to go with any of these options, the PDGF, the BMP, or the cellular allograft. All of those are more price effective for me because I don't have that extra surgical morbidity that I'm dealing with in terms of extra post-op visits, extra post-op discomfort, and extra surgical time. So I feel that I'm always cost ahead when I perform those grafting procedures as opposed to autogenous bone. And so there is a change as you go in price with those, and so really we try to establish with the patient what their goals are. Are they trying to under-engineer a case every step of the way, the least number of implants, not worried about the cosmetic result, just purely functional? Then I'm already in touch with the fact that we probably are going to wait longer and allow the less expensive materials to catch up, because that's really probably the biggest impact is the speed of the grafting materials. In other words, we could use a xenograft and a sinus, and we know eventually we're going to get a phenomenal result with just that. It's just the timing of it may take longer. So we try to basically bring the time, the need or not the need for autogenous bone graft, and then the patient desires together, and they usually make the decision for me without specifically talking about the graft. They're just telling me the case-wide, what their goals are, and that helps me define where to go rather than actually ask them, you have this product for this price, this product for this price. I don't usually get into that much detail, or rather get an idea of what their needs are and try to help dovetail the appropriate product for them. I think with any growth factor that we utilize or any cellular graft that we utilize, there's always a risk for complications, and I think it's really important that each clinician familiarize themselves with each of the products that they're going to utilize and have a good understanding of what the potential adverse effects are and how to potentially avoid them. For example, we have some patients that are opposed to any kind of transplant. And they perceive, a blood transfusion, a cellular graft, any of that off their list, because even though it's a very, very low perceived risk, it is a risk that isn't present probably with the growth factors, for example. So we try to look at each one. Swelling, for example, a little bit more swelling with the BMP2. And so that's something that I'll evaluate that patient, and I'll see what their needs are in terms of, are they going to be back in the public eye in 2 days? If so, I probably wouldn't want to go with the BMP2 because I think I get a little bit more swelling. Is that going to impact the outcome? No, I think the outcome is still excellent. It's just we try to look at that list of potential complications and then pick our product based on what the patient's needs are. As far as absolute contraindications, I really don't have a contraindication to any of those materials. I would use all three in my own body, depending on the actual case and what was needed. Therefore, the contraindications tends to be more what the patient's concerns are, more than an actual contraindication. There are certain things, again, if you read the package inserts and you use them on label, you shouldn't have any problems. BMP2 is not really recommended for around periodontal defects. That's not where it was studied. So a contraindication might be if there was significant regeneration required around a natural tooth while you're doing the implant procedure. Like one of the cases I showed was a very large defect, periapical defect of where a tooth was removed, but it also involved the adjacent tooth. And so in that particular case, I think potentially the BMP2 isn't as well studied for around natural teeth, but we know that it has a very robust bone formation and probably has much more extensive studies on bone formation than PDGF does. So again, we kind of look carefully at what the goals are of the individual case, but I don't really see any major contraindications to any of them if they're used as they were designed and as has been reported in the literature. I think the future of tissue engineering is just going to make our lives that much easier, and that we're going to be able to, again, minimize the use of autogenous bone. I think we're going to be more predictable with our results. Right now we are very predictable with the actual implant survivability, but we all know that that's only part of the equation. It's the aesthetics behind it. It's not just did it work? And so I think as tissue engineering technology improves, one of the things I see is a much more aesthetic outcome can predictably become available. We know that cases where you've had multiple surgeries attempting things, maybe now we'll get it right the first time because we'll have a more robust response from that initial surgery, and we'll hopefully have more predictable outcomes with the procedures that aren't quite as, our implant success, is 98, 99% success, but maybe our grafting procedure is 85% successful and has these little, well, we got most of the way there. Hopefully we'll improve that predictability. Well, I am definitely an avid skier and snowboarder. I try to get out heli skiing and enjoy the mountains whenever possible. One of my newer hobbies, I've taken up wine. I have a very small Pinot Noir vineyard that I've been working and learning towards. So I think it's always important just to stay young by taking on new challenges, and be it skiing, car racing, wine, piano. I enjoy all of those things in addition to obviously family time with kids and family. I always enjoy and make sure that I take out the time to enjoy that part of life as well.